Good morning, everyone. This morning for Grand Rounds, we have our Pediatric Residency Distinguished Lecturer. Dr. Maya Neeley grew up in Florida and graduated from the Honors Program in Medicine through the University of Miami Miller School of Medicine. She has always loved working with children and has discovered her passion for pediatrics during her clerkship year. After medical school, she moved to Cleveland, Ohio, where she completed her pediatrics residency and chief residency at Rainbow Babies and Children's Hospital. In 2010, she moved to Nashville and has been a pediatric hospitalist since that time. Dr. Neeley discovered her love of education during residency. She is unsure of which makes her happier, engaging in clinical care or working with learners, and she is grateful to work as a hospitalist where she gets to do both. While she enjoys working with learners of all levels, she has focused her efforts particularly toward medical students. She has been involved at Vanderbilt University School of Medicine within a number of roles: Master Clinical Teacher, College Mentor to Batson College, and Pediatric Clerkship Director. She has a particular interest in creating safe learning spaces where students can feel comfortable engaging in dialogue, learning through missteps, and developing their clinical reasoning skills. Dr. Neeley is both honored and excited to speak with you today about a tool she uses frequently in practice, debriefing in the clinical setting.
Good morning, everyone. I'm Maya, and I am so excited to be with you today to discuss how to use debriefing as a practical tool for education and another tool in your educational box to use for your learners. Can everybody hear me okay in the back? Wonderful. My first slide is my disclosure slide, and I honestly have no disclosures to let you know about today. I wish I did, particularly the one about stock ownership, but I have none. I hope to have one day. Before I begin, I would definitely like to say some thank yous. So a few months ago, I wrote a paper on debriefing in the Journal of Pediatrics, and I have to thank some colleagues and mentors that helped with that, Joseph Gigante and Travis Cook from Vanderbilt, and Mike Ryan and Robert Dudas from the Council on Medical Student Education in Pediatrics, or COMSEP. And then after that, the AAP's Pediatrics on Call podcast asked me to come and speak on that article, and I want to thank them. And then finally, I would love to thank your chief residents, Kelly and Amelia, who listened to that podcast and asked me to come and speak with you on debriefing. So the lesson in that story is sometimes take a little opportunity and then bigger ones can come from it. I consider myself both learned in debriefing and still learning. So at any point in this talk, if someone has something new to contribute to add to the conversation, please raise your hand and share with everyone. I think conversation is always really helpful in these talks. My hope today is to encourage you all to debrief more often about both big and small errors that occur in the care that we give, so that we can really use those missteps as learning opportunities for growth and improvement as individuals and as teams. So our learning objectives today are to understand the purpose of debriefing and experiential learning, to explore scenarios in which clinical debriefing might be useful, and then to build a framework for clinical debriefing. I'd like to start by just asking a question of everybody. If you could raise your hand, if you can think of a scenario within the last month that would have benefited from debriefing. Yeah, I see some hands. Love it. And then did you? Yeah, I see some shaking. I see some shaking heads going this way. So in two recent studies of both U.S. and Canadian physicians, even after big sentinel events like an emergency room resuscitation, less than 25% of providers had participated in a debrief session, though over 90% felt that one would be helpful. So we think we should debrief, but we often don't. So what are some barriers to debriefing? In a study from 2014, Sundhu et al. Assessed post-resuscitation debriefing practices in Canadian pediatric emergency departments. When participants were asked to name barriers to debriefing, these were the top 4 items noted. Time, and time, which I think is a barrier when we ask questions about most things. workload and other pressing work obligations that had to happen that interfered with time, and also the ability to stay present immediately after a scenario that required a debrief. No identified interest or need on the parts of maybe the senior doctor as well as some of the learners, and then a lack of qualified facilitators. Now, in the brief time I have with you today, I anticipate that I will probably be able to make no changes to the time you each have in a day or the workload that you are tasked with. But what I do hope to do is convince you that debriefing is useful in many clinical scenarios and can be a meaningful learning tool. And I also hope to give you a framework to utilize to help you feel more qualified to facilitate such conversations. I forgot that I animated that slide. I recently read a wonderful book that I'd like to share with you by a woman named Amy Edmondson, who's a professor at Harvard Business School. And reading this book really highlighted for me that a lot of the learning that our students and residents, and honestly ourselves sometimes, are tasked with is very complex and nuanced, that it's oftentimes new, and that within that learning, some degree of missteps are going to happen. And while it's hard to accept that, because I think we all kind of come into work constantly kind of wanting to do our best and wanting to have the best outcomes, it also emphasizes the need to really use those missteps as growth opportunities. So why do these missteps occur? Again, I don't think anyone comes to work thinking, let's see what kind of errors I'm going to make today, or let's see how I can get a poor outcome from some conversation that I have today. I think sort of ingrained in debriefing is this belief that we are all sitting here trying to do our best work. But remember, though, it's a complex environment filled with complex tasks. Sometimes we are preoccupied with the wrong task or tired from being post-call. And one of the causes of mistakes can be inattention. Lack of ability is another reason. How many times are our learners or ourselves tasked with a novel situation? I still remember I had to do at least 10 LPs my intern year before I figured out what the POP was that everyone was trying to teach me about. And we also do challenging work, or what we're looking for in the moment to assist us in some task isn't always present. The same medication or treatment doesn't work every time, even for the same patient. And finally, as our patients begin to have more and more medical complexity, there's a certain amount of uncertainty because we just don't always know what the right way forward is. And with that comes a certain degree of experimentation to figure out what might work. In addition, we're in a very complex environment. Every clinical encounter has myself, a patient, a team, the hospital system. All of these things make our work very complex. In her book, Edmondson talks about unhelpful practices for learning from errors and says that oftentimes we don't take the time to really try to pull out what could be done better. So we'll often just skip the analysis and say something like, I'll just try harder next time. Or because of a lack of time, we'll do a superficial analysis and say, it didn't work, I'll just try something else. And then finally, we'll sometimes have a self-serving analysis where we'll think, I was right, but someone or something else messed this up. But instead of skipping the analysis, what she suggests is to try thinking carefully about what went wrong and what factors might have caused it. Instead of doing a superficial analysis, to try really analyzing what the causes of the failure suggest about what to try next time. And finally, instead of self-serving analysis, to understand both our own and systemic contributions to the failure. So this takes us to debriefing. There are lots of different definitions out there, but they're all basically the same. This is from Gugulis et al. And debriefing is defined as a conversation after events to explore actions and thought processes to promote effective learning and to identify strategies to improve future performance. One member of the group, a facilitator, usually helps others analyze, synthesize, and evaluate issues, and then extrapolate and apply lessons learned for future situations. Within that definition is included this thinking carefully, analyzing, and understanding that Edmondson discusses as her advice on learning from errors. So let's go briefly to history of debriefing. So debriefing's historical roots began in the military in the 1940s, actually, during World War II, and it's attributed to U.S. Army General and Chief Historian Samuel Marshall, who began conducting interviews after combat, where troops were interviewed in groups immediately after a mission or as soon as the fighting had ended. And the aim of those sessions was to chronically reconstruct and describe the event to the smallest, most minute detail by those who participated in it, and then review and assess the results of that mission to gather intelligence to inform future strategies. While this practice originated and was honed in the military, it has since expanded to other high-stakes industries, including aviation, the business world, and more recently medicine, where it has been shown to improve team performance and patient outcomes. Adult learning theory aims at really understanding through doing. And Kolb's theoretical framework of experiential learning is a cornerstone in the educational foundation of debriefing. It highlights this concept that education through doing and through self-reflection is essential and necessary. It is a 4-stage process, as you can see up there. So the first stage is a concrete experience. An intern in the ED has a febrile neonate and gets to do their first lumbar puncture. The second stage is reflective observation. So after this intern's failed attempt, I'm sorry if any interns are here, LPs are really hard, like only 50% of the time are they successful, I feel. But after that failed attempt, they think about what wasn't optimal, maybe about how they did not achieve the correct angle with a needle. And then the third step is abstract conceptualization, which is constructing new ideas based on this experience and this reflection. So this learner might think about adjusting the height of the bed next time to an optimal position so they can visualize the correct angle of insertion better next time. And lastly, in active experimentation, the learner tries out that new idea in another experience, and the cycle begins again. So debriefing really encompasses both this reflective observation and this abstract conceptualization, reflecting on and learning from the experience so that you can actively try something new next time. This reflection is really critical. The terms debriefing and feedback are often used synonymously in healthcare simulation literature, but there's a big difference between the two of them. So feedback is very similar in that it also provides information about a performance with the intent to modify thinking or behavior to facilitate learning and improve future performance. However, feedback is generally viewed as one way, generally a hierarchical figure. So your intern if you're a student, the senior resident if you're an intern, you're attending if you're the senior resident. That figure gives you an answer on how to do better. However, with our words of thinking, analyzing, and understanding, the debriefing process is certainly meant to be more self-reflective, interactive, and bidirectional with the learner in front of us. There is a facilitator there, but their primary role is really to provide guidance and support, not necessarily answers. The answer should come through self-reflection that's guided. So what are some elements of work that we can debrief on? I like to divide them into technical skills, behavioral skills, and organizational issues. So technical skills can include things like the knowledge, skills, and behaviors for a specific task. We mentioned lumbar punctures already, physical examination, bag mask ventilation, history taking. I think oftentimes we think that debriefing has to be about a sentinel event where there was either a huge mistake or it was a big event like a resuscitation on the floor. But oftentimes these small things we can do on a day-to-day basis. We can think about elements of work like behavioral skills such as communication, leadership, teamwork, situational awareness, and decision-making. And then finally, it gives us a chance to think about organizational issues such as resource management, safe practices, culture, policy, and procedures. So what scenarios can we debrief on? Here's a list of recent events that I have debriefed on. A pediatric resuscitation where there was difficulty obtaining an airway. On morning rounds one day, a family grew frustrated with our care plan for the day. And then a patient on the behavioral health service runs out the door during rounds and onto the elevator to try to leave from the hospital. As you can see, each of these approaches a different element of work. The first, a technical skill, the second, communication issues, and the third, hospital policies for safety. One thing I was thinking about when I was completing this is oftentimes we debrief when an error happened or when things could have gone better. But does it always have to be a scenario where we note that something went wrong? And I've been thinking a lot, and I don't think so. You can learn equally from situations where all the right things happened and you want to reinforce that learning and those skills and self-reflection and the right things having happened. And plus, even when things go right, it doesn't mean that we still can't do them more optimally. So you can consider how you can do things even better moving forward. The other thing I tend to think about is sort of like what triggers me to consider doing a debrief. And so I am admittedly a feelings person, so I tend to debrief after situations where I have or I have seen team members have an emotion towards something because I think that emotion is telling that they might be sort of engaging in some self-reflection to begin with over that scenario. I will also tend to debrief if I have learned that this is the first experience someone has had with something, or when it seems that we walk out of a room, and again, I'm a pediatric hospitalist, and when things seem just heavy, because I feel like that is telling also. And I've been thinking as I was doing this talk that I think I will be more intentional in the future about debriefing when something has been successful so that we can really make sure and reflect upon why that happened to use that moving forward. So we have reviewed elements of work that we can address, and in their article from 2015, Kessler et al. Share 7 clinical setting categories that provide fodder for thinking about those elements. These include a critical presenting complaint like respiratory distress or unresponsiveness, a critical final diagnosis like septic shock or stroke, acuity, where somebody might come in with abnormal vital signs and a heart rate of 200. Disposition, like an ICU transfer, especially if it's unanticipated. Location of care, like the emergency department or trauma bay. A true failure, where patient harm has been involved. Or interpersonal, when we think about families who are upset or disagreements between care providers. And I think these are great kind of clinical settings to think about debriefing in. So let's move on to why I personally think that debriefing is most important. It is really important for experiential learning. It's really important for adult learning. It's really important for growth. But I personally think it's because you're not alone in trying to make sense out of an encounter. So in a study from 2019 by Sweeney et al., the authors held semi-structured interviews with anesthesia residents from the Hospital of the University of Pennsylvania who had experienced a critical event. These critical events were defined as an operating room crisis, disruptive behavior in the operating room, or a communication breakdown within the operating room. They identified 4 stages the residents went through after such a scenario, but I actually just want to concentrate on the first. And this was deemed the stage of internal dialogue. Within this individual processing of an event, learners were often concerned with how they were supposed to react, if their emotions were correct, whether conversations with others were appropriate, and were found to often second-guess themselves and their knowledge base. One participant in the study stated, "I was worried they would think, why is this incompetent resident asking so many questions about this event? And so I just ended up blaming myself for the situation entirely." Another said, I didn't ask for a discussion afterwards because as a woman, I didn't want to be labeled as too sensitive. And finally, many were worried about their image, if their reputation would be impacted, and how they would be viewed if they asked for a debriefing. So this paper really solidified in my mind that oftentimes after patient care experiences, we have these internal dialogues. And that if we can try to make these debriefs a part of the culture and a part of the norm, then maybe we'll have the chance to assist a learner in finding a lesson without being alone in doing so. And hopefully, in finding that lesson together, we can try and limit their distress as much as we are able to. So this takes us to a basic framework. So many debriefing models use 3 steps. They all use different words to describe them, but the basic premise is usually the same. And that is to first have an understanding of what passed during an event, to then reflect on why it passed the way that it did, and then consider what improvements can be made for the future. And those are separated, and this is a common model used, the Gather, Analysis, and Summary model, or the GAS model. Recognizing, though, that especially with missteps, errors, failures, however you want to call them, some emotions can be unveiled. Many models also put another step into the mix, and that is of reactions and feelings that need to be sorted through, as kind of evidenced by that Sweeney article. So the model that we're going to go through is this GAS model, but first let's go to my starred orange box talking about reaction. I want for just a quick moment to separate emotional debriefing from debriefing to learn. Our focus today, and for debriefing in general, I think, is to debrief to learn. That is the ultimate goal. How can I take this experience and do better in the next similar one that I have? But in any given situation, for a moment, we need to gauge the emotion in that room to understand if debriefing to learn is possible in that moment. One thing we can start by doing is saying, how did that feel? If the emotion is so intense that we are receiving back, then we might not be able to take on the cognitive load of also taking away a lesson. If the emotion is present to a lesser degree, often being with others who share those same or similar emotions can be both validating and comforting in and of itself, and learning can occur in tandem. So I know that I have been in this space before where the emotions after an event were so strong that my body and mind could not honestly take in anything else. And I share this openly with you because I don't think I'm the only one in this room that has felt overwhelmed over a patient experience. And while we might not be able to educationally debrief in that moment, it is still important that once we uncover that emotion, that we are able to provide whatever support we are able to that individual, knowing that we are not fully trained enough to provide them with all the support they need. This is where psychological first aid comes in, which is to provide support which does not intrude, to protect people from further harm, to normalize their emotional experience and response, and then to help them connect to information, services, and social supports like your employee assistance program. The focus of psychological first aid is really to assist a clinician, caregiver, to consider what they need to feel safe and supported as they're going through an event. I bring this up because this is not the time to have a debrief to learn. We can consider having a cold debrief or a delayed debrief for people who are having these strong emotions, but we need to just make sure that that's not the right kind of timing for what we're trying to do to debrief to learn. For your debriefing, if you are able to debrief to learn, to be most successful, I think one key tenet is participants need to feel psychological safety. I think central to the tenet of psychological safety is this ability to fully participate without fear of judgment, retribution, embarrassment, etc. I have heard it compared to a container, psychological safety. And that container can hold the water both when it is still and when it is tumultuous. That container is so strong that it can withstand and support whatever is inside. Psychological safety does not imply that you will not feel uncomfortable or that you won't feel stretched. We hope sometimes the best learning happens when you're stretched. But it implies that when you do feel that, you will have others there to support you. And psychological safety allows spaces for open communication, voicing concerns, asking questions, seeking feedback, and above all, I think honesty. I think deep down, the more that you provide and can provide a caring environment for your learners and your colleagues, one in which you hold their best interests highly and one in which they know that you do, then you're kind of already moving in that direction of psychological safety. Okay, so in his article, in his recent article from Chest, Kumar suggests that there are 3 steps to enhancing psychological safety. Hold on a second, I'm going to grab a quick sip of water. We begin with step 1, which is setting the stage. Debriefs oftentimes begin with this basic assumption, and it can be signposted. We believe that everyone here is intelligent, well-trained, cares about doing their best, and wants to improve. This is about improving one's own and the group's performance, not about criticizing. Absence of judgment and confidentiality are 2 safety guarantees that also need to be emphasized. There will be no judgment, criticism, or blame, and nothing discussed in this group will leave this room. Our second step is inviting participation. We're going to speak one at a time without overlapping. What each of us says is too important not to deserve our full attention and listening, and everyone learns from each other. This really allows for situational humility, intentional listening, and then allowing different perspectives to be heard. And then finally, our third step in providing psychological safety is responding in a way that is productive. Acknowledgement is always good. I appreciate you sharing that with us. And encouraging learning, right? I encourage us to use this time as a learning opportunity. Now that we have talked about the importance of psychological safety through the entirety of the debrief, let's move on to the framework that we can use. The first step is gathering. So gathering serves the purpose of learning what transpired during the event and gathering all the facts. You can start by asking for a synopsis by someone central to the scenario. It can be action by action or chronologically, but it needs to be factual. Asking for additions or clarifications from others, and then paraphrasing a brief summary of what transpired, using words like, does this sound correct, or correct me if I'm wrong, which allows for further description if agreement is not present. What we're really trying to do in the gathering stage is create a shared mental model to use as a background for our analysis phase. Each event is recomposed with everyone's insight, perception, and experience, and those insights, perceptions, and experiences may be slightly different. We are really trying to leverage the collective knowledge of the group to gain the most accurate account of events for us to reflect upon. The second stage of the debrief is the analysis or reflection stage. And this stage should really be the one that takes the most time in your debrief. You are really trying to pull out how people think the encounter went, what was good, what was bad, and the why behind the individual or team's actions. One of the things I think we're all guilty of sometimes, especially myself, is assuming that we know why someone did what they did. And when we do that, we can sometimes teach to the wrong thing that needs to be changed. So the purpose of this analysis phase is really to be learner-centered and allow them to relay their thought process. One tool we can use to promote this analysis is called plus delta. Plus indicates actions carried out by the team that are deemed timely and appropriate, and delta indicates actions which the group of participants deem as needing kind of further improvements. Open-ended questions are especially helpful in trying to gain reflection through this tool. Notice the use of what questions, what worked in this scenario, what is the best thing we did, and how questions are equally helpful. How could that have been improved? How could that have been done differently or better? It's also helpful, I think, to remember that reflection seeks not only to find out what was suboptimal, but also what went right in the scenario. Each is important in growth. Figuring out what you're doing well and why that is so, and figuring out what you could do better and how to go about doing that. Note the wording that is used here. We don't ask, what is the error that you made here? Or what is the error that was made here? That doesn't promote psychological safety and may elicit some defensive mechanisms that can halt the learning process. Instead, we use the words, what could be done differently, or what could we have done differently here? Capagna, in his article, Strategic Debriefing for Advanced Simulations, suggests taking that model one step further. You ask your plus and delta questions and then inquire further to gain insight into intent, the why, or what were you hoping to achieve. I want to pause for a moment here because I think this analysis phase focuses a lot on the use of questions to facilitate reflection. But I want us to remember that it is not only the language that we use here that creates psychological safety, but also the paraverbal communication that is utilized. You can say the same sentence two ways, and it can come across very differently. What were we hoping to achieve here? Seems very psychologically safe. What were we hoping to achieve here? Doesn't seem to carry the same message. Another tool to use to pull out this reflection is called assertion investigation or advocacy inquiry, which combines two effective communication techniques. In advocacy, you state your views, and in inquiry, you ask questions related to that view to facilitate conversation. We can use kind of three prompts to help us complete advocacy inquiry. I saw, I think, I wonder. For example, after a resuscitation, I might say to a learner, I saw that you moved from the foot of the bed to assist in putting pads on the patient. I think that the best position for the leader to generally be is where they can see everything, like the foot of the bed, and I wonder why you chose to move. The learner might then respond back to me, I thought my role was to stand where I could notice what gaps I needed to fill. And then I can teach to that kind of initial kind of thought that the learner has. And then finally, we get to the summary steps. So what are the main learning points here that we want to take away? I found an article that said that you can have between 5 and 9 learning points after a scenario. But realistically, I just think that is way too much. I think that is way too much. That is a lot of learning for any scenario or event. I tend to think that between 1 to 3 learning points is really like a good sticking point. And then feedback is what helps bring those learning points together to formulate a specific plan to improve future performance. The facilitator can summarize the learning points and may either reiterate or tweak or suggest improvements for the future. Remember, this feedback is meant to be formative, meaning the purpose is for improvement through practice. It needs to be actionable also. So to this learner during the resuscitation, I might say, I understand how you could feel that way. That is oftentimes the way it works when you're the leader on the team, right? You fill in gaps of other people. But as the leader of the resuscitation, your biggest role is to always be the eyes of the room. And in that role, if you see an area that needs help, it's best to direct someone to do so. And then you can ask for further questions or clarifications. Or after you let them know what that role is expected to be, you can just say, what do you think might have improved this? When I completed my research on this topic, probably 99% of the articles that I pulled that exist are from the simulation realm. So most all of the understanding we have in debriefing is from simulation, which is great, but we really want to move debriefing into the clinical setting more. And studies have shown all of the following when you do, that there is improved effectiveness in teams that debrief compared to those who do not, that debriefing programs that clinically I think most exist around cardiopulmonary events have shown improvement in rates of return of spontaneous circulation, neurologic outcomes, hands-off compression time, and delays to first compression. And in fact, debriefing programs after cardiopulmonary events have been so effective that the American Heart Association guidelines actually recommend the use of debriefing after resuscitations always to improve future performance. In a study by Gugulis, I think I'm saying that correctly, et al. From Australia, they actually assessed the impact of a scripted post-event debriefing tool in their NICU. During the 2 months of this study, debriefing sessions were conducted at the earliest opportunity after major clinical events, which were described as acute patient deteriorations, emergency C-sections, and any other critical events as decided by the team. Sessions were limited to 10 minutes for practicality and to encourage participation in a busy clinical environment, going back to that time barrier and workload barrier that we talked about. Well, so let's take a quick look and see how it is modeled after that GAS framework. So first, there's an introduction and creation of a shared mental model. We're going to do a quick debrief to improve our performance and the care we provide. Let's start with a description of key clinical events. That's our gathering stage. Then they move into this plus delta framework. Let's talk about our performance, what went well, and what was challenging. This is the analyzing phase. I really appreciate how in this particular framework, they separated that plus delta into different categories, one for logistical things, which were like environmental, one for equipment, which was availability and functionality of things that were present in the room, one for procedural, which is sort of like the use of and access to protocols and guidelines, and one which was personnel, which included things like clinical knowledge and teamwork. And then finally, they talked about what is to be replicated and changed for future events and identified issues that required follow-up, which is that summarizing phase. A survey was sent to participants both before and after that 2-month trial period over which the tool was implemented, and it included questions on the nature, timing, focus, and frequency of debriefing opportunities after those major clinical events, as well as the impact of being involved in a debriefing session. And using Mann-Whitney U-test to compare the responses, these areas all showed a positive change in ratings after the tool was implemented, with a p-value of less than 0.05 considered significant. After the debriefing script or tool was introduced, people felt there was an increase in the frequency of involvement in debriefing after major events, that there was a reduction in the time elapsed between the event and the debriefing session. There was additional learning opportunities that occurred because of the debrief. It also provided opportunities to work through stress, provided a forum to identify logistical equipment and procedural issues, improved team communication, and then finally improve the professional safety of the debriefing environment. Another study was done in Calgary. So this info cognitive aid was created as a joint venture between the Department of Emergency Medicine and the Department of Pediatrics at the University of Calgary to promote debriefing after resuscitation in their emergency departments. As you can see, this debriefing program incorporates elements of psychological safety. At the very top, there's a basic assumption. We believe that everyone participating in patient care is intelligent, capable, cares about doing their best, and wants to improve. Plus delta, which is kind of in that first area. What went well, what could have been different, and then feedback. How can we do better? As was mentioned earlier in this please remember area, one of the goals about debriefing in general is to identify participants who may benefit from more support or counseling, but to not make that the primary focus of the debrief itself. And so it says that under the please reminder tab. And each debrief, again, because of that time and workload barrier, was meant to be fast, taking between 10 to 15 minutes. These debriefs were all led by a charge nurse who was always sort of present at all times in the emergency room. In a follow-up study by the same author, 30 interprofessional healthcare workers were interviewed about the tool's introduction. Of those, 16 were nurses, 3 were pharmacists, 9 were physicians, and 2 were respiratory therapists. 97% said they learned lessons to provide better patient care. 87% reported improved relationship with team members as a result of the debriefing. 83% reported emotional acknowledgement, and 90% reported that debriefing helped cope with stress. So its impact, I think, can be far beyond just learning. And as you can see, it had an impact on that, as well as handling the emotions associated with an event and emotional stress and teamwork. One of the main things that can help debriefing be brought into the clinical setting is to have facilitators feel comfortable with it. And I think these two studies kind of talk a little bit about how a framework or script can be really helpful in doing that, and again, setting expectations that it will be done. I think the other thing is that to get comfortable with debriefings, you really have to practice at them and then kind of do self-reflection and ask for feedback on how things went yourself. When I started doing debriefs with my learners, I started kind of with like small chunks of little bits. So I would go into a room, and if I had to take over in the room, if the family was upset, when we would walk out, I would ask the senior resident and the interns a plus delta about myself, so that there would be like, I think it's a little easier sometimes. So I would say, hey, what did you see that I did that went well, and what could I have done better about? And so one, I think it kind of made it okay to talk about me. And then also, I think they understood that I'm still trying to learn. So if I'm still trying to learn, and I've been doing this for a long time, it's okay for them to kind of be learning too. So we talked about debriefing and kind of moving it from this simulation realm to the clinical arena. And now I'd also like to talk about moving our debriefs from a group of people to just an individual debriefing. Individual debriefings, I think, require a very high level of psychological safety. So I think they're really best done after a trusting, caring, somewhat longitudinal relationship has developed between an educator and a learner. And I honestly worry that I've put individual debriefing, but I think that might be a misnomer. It is still concentrating, I think, on a team approach to an issue. Anything we learn, we can learn together. There is an us here. So one of the tools that I think can be especially helpful to individual debriefing is this TALK framework, which really kind of goes through that GAS framework, just like we had talked about already, but it kind of distills it down. So if it helps you to have a framework to work through, I thought this was a quick and fast one. So the T stands for target, which is to choose kind of the focus of your discussion. So after an encounter, what shall we discuss to improve the patient care? And so that helps the learner kind of decide what they'd like to kind of concentrate on too, or what they noticed was problematic. Analysis is A. So explore how to repeat successful outcomes or identify areas for improvement. I agree. That part went really well. How can we do that again? Or, yeah, I agree. That part was a little challenging. How can we do things better? L is for learning point. So understand the little clinical pearl. What can we take away from this experience? And then K stands for key actions. So to agree on solutions and take on responsibility for changing something in the future. What are we going to do moving forward? I really hope that each of these tools and this overall GAS framework can really provide you with a jumping off point for starting your own clinical debriefing sessions, whether it be with a whole team or an individual learner. So let's kind of get to our takeaways. So debriefing supports experiential learning, and we can debrief on a multitude of clinical scenarios to improve technical, behavioral, and organizational skills. That frameworks can help guide us through the debrief, One is the Gather, Analyze, Summary framework. A cognitive tool or script such as talk or info might be helpful to you. And then finally, I think learning is really hard and complex, and medicine is really hard and complex. So learning in medicine is especially hard and complex, and I think that debriefing can really help support our learners and be an instrumental educational tool for us. Thank you for allowing me to speak today. Here are some selected references, and I am more than happy to take questions. And in the spirit of learning and growing, if you have any feedback, I would love for you to email me at maya.neeley@vumc.org. I have 3 E's in my name, and they're not all next to each other. Thank you. What questions do y'all have? Yes, in the back.
I was wondering if you had any insight or tips for debriefing on like patients who are in the hospital for a long time, or like readmitted patients, kind of like less of like acute events and more just like prolonged experiences that might be taxing for residents?
Yeah, I think that this is where we kind of try to separate debriefing from learning and emotional debriefing. I feel like oftentimes with those readmissions and the patients that are here for a long time, where I think the illness kind of has this waxing and waning course, I think an emotion that I have noticed a lot in my learners is both kind of sadness and frustration that we're not able to do more. And so I think first those emotions need to be kind of talked about and delved into, because those can be hard to carry with you. And then part of that, I think, can come from, okay, like, well, what are some things that we can learn about this experience? So if it's a readmission, and I'm going to be honest with you, I'm a hospitalist, a lot of readmissions cannot be changed. But is there like a learning pearl that we can take away from that? If somebody has had a waxing and kind of waning course, was there something that we could have noted earlier on that might have given us an opportunity to kind of engage in this particular problem sooner? So I think in those cases, it's just really important to figure out like what your learner kind of needs in that moment, and whether it is more, I think, emotional, or whether it is more, could I have done something differently? And I will say that a lot of times in my emotional debriefing that I will sometimes do, I'll try to tell learners, like, you can do all the right things and still not get the outcome that you want. And you really have to learn, like, to really be thoughtful, like, could I have done something differently? Or is everything that I did the right stuff? But still sometimes the outcome isn't what we want it to be necessarily. Does that help answer your question?
Yes, thank you.
Yeah, of course. Yes.
First of all, thank you for the presentation. From your personal perspective, what sort of words of encouragement would you have for trying to break those barriers? As you mentioned, like sometimes time can be a limiting factor, or sometimes we lead ourselves by unconscious biases, like, why should I try to change this when this is the culture here? Or why should I try to make an effort when time can be limiting sometimes? Like, what would you encourage, or what would you say to people that are trying to, like, take that first step on becoming a trigger for change?
It is hard sometimes to change culture, right? But I will oftentimes go back and say something like, I know that there are a million different tasks that we all have to do today. But I'm standing here and I'm seeing that all of those tasks are going to be influenced if we don't sit here and talk about this right now. And so let's take the time right now to do this. And then I think all of our successive tasks will sometimes actually be done kind of more efficiently because our mind is not on this, right? Like, I mean, I think we've all been part of patient experiences where we don't debrief, and that scenario is in our mind for the whole day and impacting everything else that we're doing, which also isn't good for the patients that we see in the future. So I really try to separate, like, this will help us right now, but it will also help us in the future. And then I think the other thing that I try to do is, like, really normalize it, right? Like, it sounds terrible saying it, but I have probably learned more from the missteps that I have made than the things I did correctly. I think because we tend to reflect upon them more, and in our minds we're sort of like, and I'm never going to do that again, right? But I don't think we always normalize that. And so I'll sometimes, like, walk out of a room if I've had an encounter with a patient and be like, that did not go the way I wanted it to, and just sort of normalize that for people so that when it happens to them, they can walk out of a room and say, that did not go the way I wanted it to. Can we talk about that? And I think that can be really helpful too, this sort of normalization as part of culture change as well. Did that help answer your question?
Yes, ma'am.
Any other? Yes.
Hi, I'm one of the hospitalists here, and I'm actually working with Dr. Fisher this week and Dr. Azara, and we have a patient, I think maybe that Dr. Fisher was alluding to, that has been here a long time and has had some medical ups and downs. But by far, the most challenging thing about this particular patient is the parent. And hours worth of communication each day. Patient's been here for, I think, about 2 months now, and each week there's a different hospitalist, and this is my first time having this patient. So I know that I am not alone in kind of the emotional reaction that I'm having to the parent, and I know that it's very, very challenging for the residents who are here 24/7, and where I get to come on for 5 days and then go my merry way. Some of them have cared for this patient for weeks on end or have been in there every night of the week. And we definitely, I think, kind of grumble and vent about it, hopefully respectfully to some extent. But what is your suggestion for how to maybe more productively or formally kind of explore all of our emotional reactions to this particular parent?
That is a great question, and I'm sorry that your team is struggling with this, and I also feel bad for that family because I'm sure that there are probably a lot of emotions that are going on for that family too in this kind of medical space. I think one of the things I have found helpful is knowing where my limits are as the kind of leader of the group. And so I had a similar scenario to this. And we have as part of our employee assistance program, we have a number of counselors, and kind of some of them are like counselors and social workers kind of combined into one. And one time when I was having the same issue where there was just like a lot of emotions that needed to be explored, I actually brought them in to talk with the team because I did not feel like I could lead that conversation anymore. I thought sort of tried my best, and I just ended up getting frustrated too because I shared sort of the same emotions, and I don't think I could figure out like how to separate myself from it all quite enough. And I thought having a third party come in and talk to us was really helpful because it also made it sounds terrible, but like as you're feeling these emotions, they're very valid and everybody would feel them. But I think there's also a lot of guilt that you feel them and a lot of like, I don't know how to not feel them. And they were really helpful at just kind of walking us through the process that like, it is okay to feel them. You are going to feel them for a while. You're feeling them together, and this is a safe space for us to explore them. But we still have to, at some point in time, hold them, separate them, and go in and be with the patient at 3 o'clock in the morning, and how can we kind of navigate that. So I think that would honestly be my suggestion for this, because it sounds like this has been going on for months, and I'm sure y'all have had kind of chronic discussions about this, and sometimes I think that can be really helpful.
the question may be tangentially related to that. And first of all, thank you for coming in and giving this talk. This was great listening to this. And I'm Nate Gertish, one of the hospitalists with Lisa too. And my question is, but with this patient, but also just more broadly, that you talk about psychological safety, which I think is really, really important in all of this. And I'm curious what you have found most successful in that sort of when we're debriefing in more that interdisciplinary setting where there's multiple different people involved that are all contributing to the care of this patient, and again, not just this patient in particular, but other scenarios too. And what tactics you've found most helpful to promote that psychological safety where people feel okay expressing, their emotions or their thoughts about how things have gone and how we can improve things? Because I know that has been at play at times with this family. I've certainly been in those scenarios where that safety doesn't exist.
I think it's a great question. And I think that, like we talked about, it's created through sort of the words you use, the silence you leave, the intonation of your voice, how you look at people, how you involve people. I think one of the things that's really important in psychological safety is to make sure that everyone has a say. And if you notice somebody being quiet, you can ask a question like, is there anything you'd like to add, right? Because then it doesn't force them to, but it leaves an opening for them to. And I honestly think that probably the biggest thing is figuring out how to sort of almost signpost, right? Like, this is a we. This is not an individual game that we're kind of a part of and a process that we're part of. Like, this is a we. And in order for us to be our best, we want everybody to feel kind of lifted. And I think that just comes across as like genuinely caring. And oftentimes that starts before the debriefing occurs, right? Like, it is always, I feel like I am always psychologically more safe with people who have put an investment in me. And sometimes that investment comes from 2 weeks ago. It's not now, right? And so I think the more we can do that with our learners, the more we can show up and just say, like, how are you today? Tell me about the dog that you got. Like, all of these things, I think, go to promote a culture that then is sustained when you're in that room. Does that help answer it a little bit?
This comment was submitted before these questions, but perhaps helpful for you too. Thank you. Appreciate you discussing one-on-one debriefing, as I know personally I've had difficulty discussing things in a large group scenario, but I have had the need to debrief on major issues when situations have occurred.
Yeah, thank you. Yes.
What suggestions do you have for someone who feels they have little to no authority to try to initiate the process?
This kind of speaks to that kind of culture change. And I hope that at some point in time, we are in a culture where, like, a debrief is like a rapid response. I don't know if y'all have like your version of a rapid response, where, like, anybody can call it, right? I think one of the things that I try to do when I start a week of service is say, we are all a team working together. And while I'm the leader of that team, I can make mistakes. We can all make mistakes. So if anybody feels at a point in time that we need to spend extra time talking over an event, I want you to let me know about it. So I think as a higher up, right, like in this kind of false hierarchy that we have created, I think it is our job to create an environment where people feel safe going up the ladder and questioning sometimes, right? Like, hey, Maya, we went in that room and that didn't go well. Yeah, it didn't. Let's talk about it, kind of a thing. But I also think that everybody on any team needs to find an ally. And I feel like when you're trying to kind of engage in disruption against the status quo or the culture as it is, it's always helpful to have an ally. So if one intern comes, right, like if one intern says, like it's uncomfortable for one intern to say, I want to debrief on that. Much easier if you have a teammate and two interns go and say, can we debrief on that? So I think one is as this, the more senior person of your team to creating an environment and to be explicit in your kind of willingness to say, if you need something, I want you to let me know. Sometimes I will try to kind of think about what you need before you have to tell me, but there will be times when I don't. I want that to, I want you to feel comfortable doing that. And then finding an ally, I think, can also be really helpful. And in that article by Sweeney, many of the residents, the anesthesia residents, never went to an attending, but they found a colleague to talk to and have a conversation about it. And so oftentimes you're going to your allies anyway, and so wouldn't it be great if as a team you then went to your kind of leader? Any other final questions or thoughts? Yes.
Thanks, Dr. Neeley. I thought that was truly excellent.
Thank you. And you can call me Maya, by the way.
Thanks, Maya.
Yeah.
As a fellow, I am curious kind of what your thoughts are to set expectations with the group early on in a week of service and say, we're going to have this planned time to either debrief or give feedback. And I appreciate your differentiating those two. I guess my question is, how do you prioritize those two? Do you more highly value the planned feedback time versus the unplanned or kind of unexpected feedback time, or are they both equally important?
I think they're both equally important, but I also think, like, I almost wish that we had more time to do debriefing all the time, because debriefing is more, there's a lot of coaching involved, where like you are not giving them the answer. They are figuring out the answer themselves. And I feel like learning happens far better when somebody creates their own answer, right? Like, I'll just take, for example, my child. It's like when he figures out how to do the math problem, that is so much better than me telling him, like, so you add the first row and then, it just, I think it makes the educational experience more valuable. So I honestly think that debriefing is wonderful with that. There are definitely times because of time limitation, and then sometimes I think we all have our blind spots about things that we are doing not optimally that we just cannot see. And so sometimes trying to pull that out of somebody in the debrief can be very time-consuming. So sometimes I think that's just the time for, like, feedback. Like, I'm going to tell you sort of what I see as the problem, and then I'm going to give you the answer and the solution to that. So I think you can toggle, and I think they're both important.
I guess just a side comment following kind of the same streamline as Dr. Novotny. From your personal experience, do you or have you seen better results in approaching debriefing in kind of like an informal and open-ended way to like make a more relaxed environment where everybody feels open to like give their opinions about the subject, or do you feel that keeping it to like a very well-structured and managed setting gives you better results?
That could be very wrong because this is my own personal experience. But as I told you, like, I'm a very feelings person and I'm a very free-form person. So most of my debriefings, I think, are a little bit more on the relaxed side of things. I really feel like, and this is probably because of how I learn also, and so it might need to be tailored depending on sort of what you know about your learners. But for the most part, I learn best, and I feel like most of my learners learn best in spaces that are very open. And so that's why I kind of have more looser sort of debriefs, if you will. But again, I think really kind of thinking about what your learner needs is key. I imagine that there are some learners who might really benefit from a more structured kind of approach to it. So I think one of the things to do is kind of to try out both and sort of see how it goes. And I think, like all things, the more I think you practice at this, the more you'll realize that, okay, I'm going to keep doing these things, and okay, I'm going to shift these things around as I move forward. Yeah. Thank you all so much. I've really appreciated the opportunity, and I hope everybody has a lovely Friday and that a tornado doesn't hit later.